Well, you just come from a challenging case with one of our medical students, and I think it'd probably be good for us to explore a little bit about what it was like for you and how we can understand the process that may have unfolded in that room.
Yeah, yeah. I felt the patient was very angry with us, and as if he didn't want our help. And I felt tense when this happened, and and I felt a little bit frustrated with him, as if I'm like, yeah, if you don't want our help, then yeah, I don't want to help you either. It was a strange experience. Like,
Yeah.
how can I understand that?
I think that's a really good question, and I think this is something that we always are navigating, whether we're in the hospital or in an outpatient office.
Mm-hmm.
How our patients interact with us is based on some fundamental aspects of psychology that are present all the time.
Mm-hmm.
And there's two words that we use to often talk about this. One is called transference, and the other is countertransference.
Mm.
So when we think about how to understand these terms, we first want to start with thinking about in the directions in which they flow. So if you have a patient and you have a doctor, both of them are going to experience each other in part of who they are, but also what they imagine the other person to be.
Mm-hmm.
And so the things that the patient experiences the doctor as is called transference. So the patient's going to sort of put onto the doctor certain things. And likewise, the doctor is also going to experience the patient in their own way, which is called countertransference. And these are words that come out of the psychoanalytic literature, but they happen all the time. The transference can be both a really helpful thing, and sometimes it can be problematic. And I think in this case, it was challenging for us.
Mm-hmm.
Generally, physicians rely on their patients to have a positive transference. That means that they might experience us as helpful, trustworthy, open, easy to hear things. But there are some patients for whom doctors are not the most trustworthy, or they may be so frightened or in so much pain that they're struggling to be in the patient role, and they end up projecting negative feelings or putting up barriers that make it harder to be connected as a unit.
Mm-hmm.
And that's when patients have a negative transference. So when we think about transference, you can always divide it by sort of its kind of energy or type. Is it positive or is it negative? We do need positive transference. Everybody does, because you're not going to trust somebody to go do something unless you believe they're going to help you. So you do rely on some amount of positive transference. And negative transference is usually something like we noticed. It gets in the way of doing what we want to do or doing what we think we would like to do for our patients. But both of these are important because they reflect something about the psychologic functioning of the patient. So we have to work to respect both things. This is also to say that positive transference can be problematic in its own way. So especially in therapy, when you're working with a patient, there are times where you may disappoint the patient, and that's part of life. Our parents disappoint us, friends disappoint us,
Mm-hmm.
and you can't go through life always thinking everything is perfect and positive. And so there are instances where, especially in psychotherapy, an excess of the positive or an excess idealization needs to actually be confronted. It has to be talked about so that a more realistic sense of human relationships can emerge. I think in this case, what was hard was this patient, for whatever reason, was really in a negative transference, and we were the recipients of that. And it can be challenging. And one of the things that we sometimes do as psychiatrists, especially on consults, is we can help medical teams make sense of the transference, because they may not have all the words or the experience that we have. So sometimes what a consult liaison psychiatrist will do is they'll step in to look at all the dynamics that are happening between the team, within the team, the patient, the unit, and sometimes we step in to try and diffuse the kind of psychology that's swimming around between them.
Mm-hmm.
What can happen, of course, is especially in negative transference. You were talking about how you were feeling a decreased desire to help in the face of all of this hostility. And that is countertransference. So that's occurring in the other direction. So based on what was happening with that patient, you were noticing that you were having your own sets of feelings, thoughts, emotions. And that's where it flows the other direction. So it goes from doctor to patient. Similarly, you can have positive countertransference or negative countertransference. You described a negative countertransference. You don't want help, I don't want to help you. But we can also have positive countertransference, which is for the perfect patient, the one you're going to stay up late and do extra notes, you're going to make extra calls. Positive countertransference is usually a good thing. We usually need that to do our job. But too much positive countertransference is also problematic because this is where you start getting into the savior types of complexes.
Mm-hmm.
So in both of these instances, you really have to keep the doctor-patient relationships and the boundaries very clear. And these are going to happen all the time because there's two psychologies that are always present. Any questions? Anything about kind of the case that you think about it now that kind of helps you to think through what had happened in that room?
When we say transference, where are we transferring from to? Like, why is it called transference?
That's a really good question. So part of what goes into the transference here is going to be real aspects of who the doctor and the patient are. But other things that start to get roped into this complex are going to be things from the past. And these include from the patient's past and the doctor's past. So it could be, for example, a certain way that a relationship unfolds. So when I am in a dependent position, so the patient's relying on big, powerful others to be kind and benevolent.
Mm-hmm.
If that patient has a lot of past experience being able to trust those others, they may have positive transference towards you and I. They can assume that we're just like everyone else who's done them right in the past.
Mm-hmm.
But for some people, they don't have those past experiences. People are harmful. People abuse them. People don't listen when they're in power. And so it doesn't matter who you and I actually are. When we step into that room, we become like the figures in the past that have been disparaging or demeaning, and thus the past sort of takes over and the real decreases. And so that can influence in both directions, both the transference, but also how we feel about a patient when a patient may trip our own wires.
Great. Thank you so much, Dr. Fleming.
You're welcome.
That was very helpful.
Very good.